Yeah. Next year, I don't know. I try to do. I'm trying to do everything now. Get home. Get it in.
I'll be in clinic on Thursday.
If we got a trip next year, we're going to go to, well, it's north of Europe, basically. We're going to Denmark, Poland. When you get to
too much.
So you'll be back again. So we will stay with the cruise. We get the furthest north of it. I don't know.
In December in Anchorage. So I'm gonna get an SUV.
Well, they will. Sure.
But not only that, but then like spring and
We may,
Fairbanks is the one that kind of pushes me over the edge where you like
we do go back. I know
if you go into the mall, if you come back and
Where it is, Jola.
it was telling me that not like this
So, the bottom line, I'm probably not that at least once. I went over here last year. A year ago. I think so. I know that for sure.
Yeah.
How was that? I know much to be already. I think so. I don't know whether I didn't know when I signed up for it last name. I've got, we went with 10 of us. One of the people said, we didn't really want to go this time. Wow. Great up there. And actually, it's even prettier because the water, the rivers were just turbulent. Because it was rainy season, so I think it's probably more spectacular. The rivers are incredible.
So that's different than
Where are you going now? Europe, Northern Europe. That is the Copenhagen, Berlin.
It's about 45 minutes.
So, Drew, are you guys doing aspirin stuff here now?
Going on right now. That's dramatic.
Right now, in this room while we're here?
We're in the hospital, but yeah, we don't do it. It's not
But at least they don't have to go to San Diego anymore.
Our nurse is kind of charged. So she knows what's doing.
Yeah.
That's part of it. I haven't done Southern South.
I didn't want to go back.
Nope. I've been quite all kinds of but I want to do have yeah. That's a private baby. He's suffering right now. I had him on the schedule. What's happening at the time?
Oh, no.
You're going to read it. You can't look at it. Let him.
It's no worse.
the old biggest hassle I got
Right.
yeah, starting here. But no, I don't go to the center, so I won't get home.
Yeah. It's like everybody else, 0 to 50.
Sure. But it was good stuff.
Yeah. Okay.
But it wasn't good.
Yeah.
Parking in Seattle is so bad. You know, the other thing is, you know, you used to
What'd you do all day? Just hang out at the beach?
then of course,
What'd you read? Anything good?
Gosh.
Okay. It's a fun read.
Did you work out the cash web?
Yeah.
No. Yeah. I got asked to do that 40 times.
We're going in Monday through Tuesday.
That's the only time I read.
Yeah. I know it's fine on vacation.
Yeah. Why don't we go ahead and get all darned it?
For those who can stay either online or in person, we're going to present maybe 2 cases. Yesterday I had no cases, and I came in this morning, we've got 2 cases to present. So Dan's got a case, and Lisa was nice enough to take a look at a patient of mine. Anyway, Katharine is here from San Diego, and thank you very much for coming. She's going to give us a review and an update on aspirin-associated respiratory disease.
So thanks for having me. It's awfully early in the morning, but I'm kind of used to that because I start seeing patients at 7:30, so this isn't painful. So I wanted to go over an overview of aspirin-exacerbated respiratory disease, a little bit about the mechanism of what we think is going on. I'm not going to talk so much about what we think is happening with the desensitization, because I think that's still all up in the air. And then very briefly at the end, I'm going to touch on a problem that I think you probably see more than just kind of your straightforward AERD patient, is the patient that's in the hospital that's having a cardiac event that needs aspirin, and potentially they have AERD, and what are you going to do to get them on aspirin, because the cardiologist really wants them on aspirin. So what is aspirin-exacerbated respiratory disease? It goes by a number of different names. It's also been called aspirin intolerant asthma, aspirin-sensitive asthma. We've really tried to move away from those terms because asthma is not necessarily the central feature of AERD. The central feature is really this chronic hyperplastic eosinophilic rhinosinusitis associated with very aggressive growth of nasal polyps. And then at some point in the clinical course, a patient will oftentimes develop asthma, but asthma is not a prerequisite in making the diagnosis of AERD. There's a movement afoot to change AERD to NERD, NSAID, exacerbated respiratory disease, but somehow that doesn't have quite the cachet associated with it, so I don't know if that's going to stick or not. Because it's really any COX-1 inhibiting NSAID that can precipitate a pretty severe reaction. We'll go through why that is. And the aspirin and the NSAIDs are characteristic in terms of the symptoms that they'll provoke, but if the patient never takes an NSAID or aspirin, the disease process both begins and continues without any exposure to the anti-inflammatory drugs. So the typical patient will present sometime in their 30s or 40s. It's more often a woman than a man. They oftentimes will give you the story where they got a head cold and their symptoms just never resolved. They began to develop anosmia, started to get chronic sinusitis, oftentimes started to get aggressive growth of polyps. And you'll oftentimes get the story where they've had sinus surgery and within weeks of the sinus surgery, the polyps are coming back again. That's how, as soon as you hear a story where the polyps came back that dramatically and that quickly, AERD has to be at the top of your list. And again, although sinus disease has to be present, as in asthma does not necessarily, so there are some people that never really develop any lower respiratory tract symptoms, but the asthma in these patients can be quite severe. An interesting observation that we've made over the years is that a lot of these patients will give you a history where even just a few sips of alcohol will precipitate acute respiratory symptoms, and more so than what you would see in your general asthmatics or patients with chronic sinusitis. So Andrew White in our division, working together with Tanya Laidlaw at Brigham and Women's in Boston, actually did a survey of all their AERD patients and found that 75% of the AERD patients experienced some sort of upper respiratory symptoms with the ingestion of alcohol. And although red wine was the most common, it was not the only alcohol. Most of them would report that any alcohol would do it, whether it was hard liquor or wine or beer. And if you compared that to patients that were aspirin tolerant, there was only about a 30% incidence. In patients with chronic rhinosinusitis, about 30% would experience symptoms. What was also interesting is that the patients that had the most severe reactions to alcohol also tended to have the most vigorous response to aspirin challenge and desensitization. And a good percentage of those patients, once they're desensitized, can actually drink their alcohol. This has led to a lot of speculation as to what it is about alcohol and AERD. Someone, I think it's the group in Larry Borsch's group, has suggested that potentially alcohol is acting as a COX-1 inhibitor. The timing is completely off on that. These patients, within a few sips, within minutes to half an hour of having their drink, will experience their respiratory reactions, and our time course for COX-1 inhibition is generally over 100 minutes. So that's not really hanging true. So stay tuned. We're now going to be bringing patients in and challenging them with alcohol to find out what mediators are being released and what's driving this reaction. So if we look at, so that one of the, Tanya Laidlaw has proposed that you may be able to use that alcohol sensitivity as a better predictor of who's probably going to react when you're doing your aspirin challenge. As you know, urinary E4 levels are very elevated in patients with AERD, and that's also a predictor of who's going to have a pretty intense reaction, but you can't do that as a routine screening. So getting back to the features, so those patients typically have sinusitis that's initially intermittent and then becomes chronic. A number of these patients will end up with multiple sinus surgeries. If you're ever in a question as to whether or not the patient has AERD, particularly when you're in that inpatient setting, you may need to do an aspirin challenge. If they have a clear sinus film, you pretty much have ruled out AERD. The asthma tends to be persistent, usually moderate to severe. The severity of the asthma really is driven by the sinus disease. We did a recent analysis and looked at the prevalence of AERD in severe asthmatics, and it's about 15%. In these individuals who have severe asthma, there's a lot of airway remodeling. It becomes a very difficult disease state to manage. But again, you have to remember there's a whole spectrum. Not everybody with AERD has severe asthma. And again, the ingestion of NSAIDs can precipitate severe asthma attacks. They looked at patients who presented with acute respiratory failure who required emergency ventilation. About 25% of those asthmatics turned out to have AERD, and were having a field reaction to an NSAID due to their lack of awareness that they were sensitive. So this is a graphic of what we kind of know that's going on in AERD. So AERD is classically associated with the profound overproduction of cystinoid leukotrienes. So you have, I don't know if I have it. Is that showing up? No. So you have your membrane phospholipids that then generate arachidonic acid that can then go down a number of pathways. So the things that are highlighted in red are decreased in AERD. So one of the first things is the cyclooxygenase enzyme 2, which is interesting to have that level low. So it turns out COX-2 is an important source of prostaglandin E2. and prostaglandin E2 seems to be very central in the pathogenesis of AERD. So PGE2, which is here in the graphic, is an important break on the whole inflammatory cascade. So in the system, you're getting an excess production of the cystoleucotrienes. PGE2 can work on a number of different receptors, EP1 through EP4, and it turns out whether it's pro-inflammatory or anti-inflammatory depends on its interaction with its specific receptors. In this instance, EP2 is the receptor that we're interested in. That's on the surface of mast cells and eosinophils. It's the anti-inflammatory component of prostaglandin E2. So prostaglandin E2 acting through the EP2 receptor keeps the mast cells from degranulating and the eosinophils from degranulating. You look at the airways of patients with AERD, not at a time of an aspirin reaction, but just at baseline, they have a large number of degranulated mast cells found in biopsy. You also see a large number of eosinophils, very high levels of eosinophilic cationic protein. And part of that is being driven by this relative decrease of PGE2. The things that are also the other counterbalance for the inflammatory cascade is lipoxins. And although when you look at polyp tissue from patients with AERD, they have all the mechanisms there to generate lipoxins, they have a great deficiency. So your two counterbalancing anti-inflammatory pathways are markedly downregulated in AERD. What's upregulated is the 5-LO pathway, so 5-lipoxygenase, which then generates your cystoleucotrienes. The cystoleucotrienes are the primary drivers of the airways inflammation and bronchospasm that you see in AERD. You have marked elevation also in the CysLT1 and LT2 receptors. We know that if you take a patient with AERD and do an inhalation challenge with LTE4, you'll get a profound bronchospastic response. To date, we haven't been able, there's presumed to be an LTE4 receptor, but that yet hasn't been identified. But we do know from biopsy specimens that both the CysLT1 and LT2 receptors are dramatically elevated in AERD. You also have elevation of PGD2 and the thromboxanes. All of this happens, nobody knows why. So the theory is that potentially you've had some sort of a respiratory illness or some other environmental insult that has led to this derangement in these pathways, but what initiates it is unknown. It's an acquired condition. There's been a lot of work looking at is there a genetic predisposition. You don't see this running in families, and despite pretty extensive work from a group in South Korea, really hasn't been any one genetic marker that kind of stands out and setting you up to be susceptible to AERD. So it's something that you always have to be thinking about as you're seeing your patient. And I've had a number of patients that have actually evolved into an AERD patient kind of in front of your eyes over the years. So it always has to be something that you're thinking about. So the known baseline abnormalities in AERD is a decrease in the PGE2, which again acts as a brake. You also have a decrease in the EP2 or the PGE2 receptor that stabilizes the mast cells and eosinophils. You have an increase in PGD2, an increase in thromboxane A2 production. There's markedly elevated LTE4 in the urine, BAL, and nasal secretions. This diminished capacity to generate lipoxins, which again are part of your anti-inflammatory mechanism, an elevation in CysLT1 receptors, and again a relative decrease in the COX-2 mRNA. In these individuals, the PGE2 that they do have, which is not enough, is under the biosynthesis of the COX-1 enzyme. So patients with AERD can take the COX-2 inhibitor without further exacerbating respiratory status. So the group in Virginia with Larry Borish has been looking at the role of IL-4 and gamma interferon. So you would think if something that's such a highly eosinophilic inflammatory process would be purely a Th2 type inflammatory milieu, but it's really a mixed Th1, Th2, and there's very high levels of IL-4 and gamma interferon, and we'll just focus on IL-4 and its impact, the things that are kind of grayed out. So IL-4 leads to a decrease in the COX-2 enzyme. It also leads to a decrease in the PGE2 synthase, so that right there leads you to your lower levels of PGE2. It also leads to decreased levels of the EP2, so that seems to be a critical component of the generation of the inflammatory pathways that we see in AERD. And interestingly, when patients undergo aspirin desensitization, one of the things that you'll see over time is a marked drop-off in their IL-4, kind of a normalization of all these abnormal pathways. And the other thing that was interesting with Larry Porsche's work is this gamma interferon. The source of the gamma interferon seems to be the eosinophils, so the resident airway eosinophils have very high levels of gamma interferon. It's actually in the granules in the cytoplasm, so when they are activated, they release very high levels of gamma interferon. So getting back to the diagnosis of aspirin exacerbated respiratory disease, the classic way to diagnose it is with an aspirin challenge. In the old days, in the dark days, when I was a fellow and we didn't have the glutathione receptor antagonists, and you were kind of doing these in patients without a lot of protection, you would get a 20% or more drop in their FEV1, along with nasal ocular symptoms. So you get bronchospasm plus ocular tearing, profound rhinorrhea. Other reactions that you can see would be just pure lower, where they don't get any upper airway symptoms. Partial asthma, where they get a drop in their FEV1 with some nasal ocular symptoms. You could see laryngospasm, and then we counted as a negative aspirin challenge if they could take 325 milligrams of aspirin without a reaction. But we can get back to this question of the possibility of silent desensitization. So in the dark days before the glutathione receptor antagonist, when you would do your challenges, the top line is a patient's first day of placebo challenge, where they were given placebo, and you're measuring their FEV1 on this axis and time on this axis, and you can see that there was no drop in their FEV1. The purple line is a patient undergoing aspirin challenge, so they got initially 30 milligrams of aspirin and had no symptoms, and then got 60 milligrams of aspirin in about an hour, and 4 minutes later had a pretty profound drop in their FEV1 down to less than a liter, which it's a little hairy. It would take multiple breathing treatments, et cetera, to get them back to their baseline. So what happens when you actually have an acute aspirin desensitization? So when you're doing these, and I think you guys are doing them now, almost immediately their nasal congestion improves. So the patient will actually, you can look in their nasal exam and see their turbinates have actually kind of retracted to the sides of the nose. Their hyperirritable airways remain unchanged. So if you did a methylcholine challenge, they still have airways hyperresponsiveness. They're now cross-desensitized to all NSAIDs, which inhibit the COX-1 enzyme. And critical, particularly if someone forgets to dose, is that you have this refractory period, 2 to 5 days post-exposure to aspirin. So if for some reason, as a fellow, you're called into the ER with someone who's just had a big reaction to aspirin, that's the time to jump on it and have them stay on their aspirin, because they've now had their reaction, and you don't have to bring them back and go through the whole desensitization process. And it is truly universal. It can sometimes be a little bit challenging to get everybody through their desensitization, but we've been able to desensitize over 1,000 patients without a whole lot of difficulty. And I'll say that we have not sent anybody to the emergency room or to the hospital. And I think maybe on 2 occasions had to use epinephrine, and that was more for bad cutaneous symptoms as opposed to respiratory. So what's the treatment of aspirin exacerbated respiratory disease? If you're not going to desensitize them, it's avoidance of all COX-1 inhibiting NSAIDs, and that's critical to teach the patient exactly what has COX-1 inhibiting NSAIDs. You need to be aware of the fact that there's eye drops with NSAIDs in it. There's a number of topical NSAIDs that are being used now, so they need to have a good list of what they need to avoid. You also just need to avoid the COX-1 inhibiting NSAIDs, not the COX-2, and again, it's an effect of the inhibition of the cyclooxygenase enzyme, so you don't need prior sensitization. The degree of cross-reactivity is roughly related to its ability to inhibit COX-1 in vitro. The highly selective COX-2 inhibitors are typically well tolerated in patients with AERD. The European literature and some people from South America have suggested that maybe there's a subset of patients that are sensitive to COX-2 inhibitors. We have not been able to find that. So we typically would just have them do their first dose in the office, just give them a dose. And then acetaminophen is generally very well tolerated in these patients. Once you get above about 1,000 milligrams, you begin to inhibit a bit of the COX-1 enzyme, and so you can have some reactions, but they tend to be relatively mild. Acetaminophen is thought to work through the COX-3 enzyme. So the drugs that don't cross-react with aspirin and AERD, so if you're not going to desensitize someone and you're not going to use a COX-2 inhibitor, you're left with pretty poor anti-inflammatories. So you're better off using a COX-2 inhibitor if they have inflammation or going through the desensitization. So what about aspirin desensitization as treatment? So it was actually first reported back in 1922. Weidel had a case where they had a patient with sinus disease and asthma. They actually challenged them with aspirin and actually treated them with aspirin. It was in the 80s. Don Stevenson and David Matheson had two patients that they were just doing a challenge with aspirin, and then the patients refused to come off the aspirin after they had their challenge because they had the profound improvement in their nasal congestion, and they were having a heart attack because their IRB did not say anything about treating patients with long-term aspirin, but since it was an over-the-counter medication, the patients are like, whatever. So they took it, and so they actually were able to see that throughout that year, their number of sinus interventions dropped dramatically. The patients were able to get off of their prednisone. So that was what really prompted their first double-blind placebo-controlled study. That was a 3-month-long study. It showed a 75% improvement in sinus and nasal symptoms, but less significant improvement in asthma and corticosteroid use. There's a number of problems with that study, kind of looking back on it. One is that 1/3 of the patients were on too low of a dose of aspirin. And then second, what we've learned, really critical when you're going to be putting a patient through the desensitization process, is you really need to optimize their sinus disease prior to the desensitization. So they should be debulked either medically or surgically, preferably surgically, because the desensitization process itself and treatment with high-dose aspirin will prevent the regrowth of the polyps, but it really doesn't cause regression of the sinus disease that's already present. They then tried to do a double-blind, placebo-controlled long-term study, but again, the patients knew as soon as they had received the aspirin because they had such a significant improvement in their symptoms, and then within 2 to 3 days they started to notice their congestion coming back. So there was no success in lining up patients for that study. So we started to look at the data in a different way then, and we looked at 172 patients, and the first thing we wanted to look at, what are the reasons for stopping aspirin? Of those 172, 46 stopped it either due to side effects or other reasons, and what were those reasons? So a big one was gastric pain. For patients that, people that are taking care of patients on aspirin, that can be a significant problem. Typically we'll treat with H2 blockers and PPIs, and anecdotally have found that the PGE2 analog, misoprostol, is actually really quite helpful for these patients that develop that gastric pain. You can drop their dose of aspirin down to like 325 once a day and treat them with misoprostol. and the PPI and H2 blockers, and then oftentimes get them back up on their dose. More problematic is the urticaria. So some people will develop intractable urticaria on their aspirin. These are not patients that develop urticaria during the desensitization, which can happen. During the desensitization, typically if they develop hives, that'll resolve as you desensitize them. But these are individuals that, having been nicely taking aspirin, all of a sudden start to develop pretty severe urticaria, and that's usually a losing battle. That's one of the main reasons that we end up having patients discontinue their aspirin. Fortunately, bleeding complications have been extremely uncommon, and that's even given the fact that we use what some would argue is ridiculously high doses of aspirin. So then what about some of the other ones that weren't due to side effects? So there was...
A question on the urticaria.
Yeah.
Since they have severe asthma, some might have been on omalizumab. Do you have any anecdotal experience there? Did the urticaria resolve?
So there's actually someone that just presented at the Quad AI from Japan, looking at AERD patients and treating them with aspirin desensitization and omalizumab. That was a study that we wanted to do as soon as omalizumab became available. I think that would be a very useful adjunct for two reasons. One, for the chronic urticaria that they develop, and then second is the other thing you'll see on the data is that one of the reasons for failure for aspirin desensitization is continued allergic airways inflammation. They address.
You said it was good to debulk them. Do these people that you take out all their polyps, do they ever become non-aspirin sensitive after a surgical procedure?
Yeah, that's a good question. We haven't seen that. There's been a couple of case reports of that where that seems to be that a large part of what's going on is what's in the polyps themselves in terms of this arachidonic acid dysregulation. I would say that 90%, so we have 10% of patients who come to us for aspirin desensitization who have a great history, have a negative aspirin challenge. So I'd say the vast majority of patients still react even with the default procedure. So there was some people discontinued it due to worsening asthma. Again, we have mostly a tertiary referral base, so these patients went back to their primary care providers, who then saw that they had an asthma flare and said, "Oh no, you're on aspirin." That's the cause of it, and had them stop their aspirin. 2 died of natural causes, and then 11% discontinued due either to planned pregnancy. So if you have a woman of childbearing age, she cannot be on aspirin during her 3rd trimester of the pregnancy. And then 4 who had the need for elective surgery. And we'll go through what our protocol is for getting through elective surgery. But in a number of years ago now, in the New England Journal of Medicine, for patients undergoing coronary artery bypass grafting, the patients that were on aspirin and stayed on aspirin through their surgical procedure actually had better outcomes than those who had stopped aspirin and did not have an increased risk of bleeding complications. So we've been able to use that to convince at least our ENTs that it's okay for them to stay on their aspirin. I have a slide at the end that'll go through the protocol. So we had 126 or 73% of the patients available to look at what their long-term outcomes. We looked at global assessment scores, steroid use, and whether or not they were on prime modifier drugs. So this was after a year more of treatment on aspirin, and their frequency of sinus infections went down fairly dramatically. Their olfactory scores improved, their nasal symptom scores improved, their asthma symptom scores improved, and ER visits also improved, all of which were statistically significant at a year. So we decided to look at the data at 6 months, and you could see very similar results in terms of decreased bouts of sinusitis, decreased numbers of short courses of prednisone, and improvement in their sense of smell and asthma symptoms. And those results were persistent, so if we had someone who responded at 6 months, that would carry out. And it also was able to show a decrease in their need for prednisone. A lot of these patients are on chronic prednisone really to maintain their sinus disease, and once you're able to get that under control, you can get them off of their chronic steroid use. So we wanted to look a little bit closer. The question we're always asked is, well, if we put someone through this, how many people are going to respond to aspirin desensitization? So in order to answer that question, you had to define what your responses were. So we defined excellent as an improvement in both all their clinical markers as well as their global asthma and rhinitis scores, at the same time with a reduction in both their topical and systemic corticosteroids. A good improvement was an improvement in some clinical markers, at least one global score, either their asthma or their rhinitis scores, and the same or decrease in corticosteroid use, and then failure would either be a lack of improvement in clinical markers or no change in their global scores or an increase in their use of systemic corticosteroids. So with those definitions, 48% had an excellent response, and 39% had a good response. About 87% of the individuals that underwent the aspirin and were treated for at least 6 months had either an excellent or a good response. And you can see under the good response, some of them with nasal improved or the asthma improved. And then non-responders, there was 4 that were global non-responders. There were 2 that actually required an increase in their corticosteroid. And then this study was done right about the time that the leukotriene receptor antagonist montelukast was being released. And some of those patients actually had that added after they had gone through their desensitization. So we counted that as potentially a failure of the aspirin desensitization, just to be cautious. Some would argue that it made perfect sense, a disease that's driven by overproduction of leukotrienes, to add on a leukotriene receptor antagonist. But then we looked at that very question: was there potential for the leukotriene receptor antagonist to be responsible for some of the response to aspirin? So we looked at this by comparing 2 groups of patients, one that had no exposure to leukotriene modifier drugs, and then those who had been on leukotriene modifier drugs for greater than a year. There were 58 subjects in each group, and then looked at the outcomes, and their response was the same between the 2 groups. So having the leukotriene receptor antagonists on board did not change your response ultimately to aspirin in terms of the long-term therapeutic profile with aspirin. That did make your aspirin desensitization a lot easier, but it didn't impact the outcome to aspirin. So this was the point that was being made earlier with regards to omalizumab. If you actually look at the patients who fail aspirin desensitization, a large number of them were IgE sensitive to allergens that were relevant in their ongoing environment. And I think that's always been, it's always argued that these individuals have a much lower incidence of allergy than kind of your typical asthmatic patient. But allergy is still a common feature, and if you don't address the allergic end of things, oftentimes your aspirin desensitization is not as successful. But a lot of these patients, because their asthma was so severe, you wouldn't have really wanted to be putting them on allergy immunotherapy in the first place, which is where I think Xolair might be a nice bridging mechanism. So what about the doses needed to treat AERD? So we know from our early studies that at 325 once a day, you have a higher breakthrough of nasal congestion. 650 twice a day has been shown in a number of studies now to be very effective. We had a number of patients who had done well on the high dose, and after a year dropped them down to 325 twice a day and had a good outcome. There's been reports that have circulated mainly in the ENT literature, particularly out of Europe, where they found low dose of aspirin to be effective. But when you actually look at the symptom scores, etc., it's not as effective as the higher dose of aspirin. We did a study looking at 650 versus 325 BID. So at the time of desensitization, patients were randomized to either receive 650 twice a day or 325 twice a day. And then at a month, they were reassessed. And if their symptoms were not completely controlled, we upped the dose if they were on the 325 twice a day. Or if they were well controlled, we could try dropping the dose. At the end, about half the patients did well on 325 twice a day, and half the patients did well on the high dose of aspirin. But there was no defining characteristic at the time of aspirin desensitization that predicted who was going to do well on which dose. So generally speaking, we recommend treating with the high dose of aspirin for a couple of months, If they're doing well, you can try dropping the dose down to 325 twice a day. And the other thing that was interesting with the high dose versus the lower dose of aspirin is that there was really no difference in terms of side effects, GI side effects, etc. So one of the other potential problems is that you might have what we call a silent desensitization, in which you pre-treated the patient, they go through their aspirin desensitization, you do their aspirin challenge, they have a great history, but yet when they do their challenge, they don't develop any symptoms. So what do you do in that situation? So we looked at our data to see if you could see a benefit from aspirin desensitization as early as 4 weeks. And again, we're able to show even at 4 weeks that their nasal and asthma symptoms improved, as well as those patients that were on steroid were able to get down on their dose of their prednisone. So if you have someone who potentially has a great history for aspirin and exacerbated respiratory disease, you do their aspirin challenge and desensitization, and they don't develop any symptoms, treat them for a month. If there's no difference in terms of kind of their asthma and rhinitis scores, you think about stopping the aspirin, although there was a letter to the editor that John Basso and Don Stevenson and Drew White just published, in which those individuals, you may want to bring them back maybe a month later and do an aspirin challenge just to confirm that they truly aren't aspirin sensitive. It's never easy. So then what about the economics of aspirin desensitization? There was a study that came out of Dartmouth in which they looked at the economics of aspirin desensitization in terms of decreasing the need for sinus surgeries, etc. It has a clear economic benefit, and then particularly for cardiovascular prophylaxis. So who do you select for aspirin desensitization? So all AERD patients except for those who are well controlled. So if you have someone that's not requiring multiple sinus surgeries, doesn't have a need for a COX-1 inhibiting NSAID, they're doing well with inhaled corticosteroids, long-acting beta agonists, and leukotriene receptor modifier drugs alone, you don't need to desensitize them. But if you have someone who's had this recurrent or chronic sinusitis, nasal polyps, or have a need for COX-1 inhibition, either for rheumatologic reasons or cardiovascular, then they're a candidate for aspirin desensitization. One of the things that always trips people up is that historically these patients have had some pretty severe, potentially life-threatening reactions, in that when they had their field reaction to aspirin or whatever COX-1 inhibiting NSAID that they took, some of them have even ended up on a ventilator in the ICU. So understandably, that makes people a little squeamish about doing a aspirin desensitization. But when we actually looked at the data, the severity of the historical reaction really had no outcome on what happened during their aspirin desensitizations. And again, I'll re-emphasize, we haven't sent anybody to the hospital during their aspirin desensitization. So why does that difference exist? And one thing, you have the patient stabilized. Two, you're doing a graded aspirin challenge as opposed to giving them the full therapeutic dose of an NSAID. And we're also using the leukotriene receptor antagonist now, which really shifts the reaction from the lower respiratory tract to the upper respiratory tract. So the patient may be scared, you may be nervous because they have this history of hospitalization, but we have very strong data to back up that there's not a need to be scared. Don't be scared. So what can you do to optimize the desensitization procedure? So we like to make sure that their asthma is stable. We used to have an absolute cutoff of 1.5 liters. I think we're down to a liter. We have desensitized some patients even less than a liter and at their FEV1. Some of these patients have had very long-standing asthma. A lot of it is they have a lot of airways remodeling, but their asthma may be very stable. They may have a low FEV1, but if their asthma is stable, you can think about doing their aspirin desensitization. But generally speaking, we'd like to see their FEV1 greater than a liter. We keep them on all their routine medications with the exception of antihistamines. So the antihistamines, so the upper airway symptoms that you get in nasal ocular reactions tends to be driven by histamine that's being released from the mast cells, and not so much by leukotrienes. We start the leukotriene receptor antagonists at least 2 to 4 weeks prior, if they're not already on, prior to their desensitization, because again, this tends to shift the reaction from the lower respiratory tract. If they have unstable asthma, you can do a short course of oral steroids to get them stabilized. Just be aware that oral steroids has no impact on blocking the aspirin reaction. So if you're hoping that that's going to make your aspirin challenge better, it won't. Use your prime receptor antagonist. And again, as I alluded to earlier, timing is critical. So you'd like to do it 2 to 4 weeks after their bulking sinus surgery. And again, you want to make sure that you're treating any concomitant conditions. I think one patient that had a real challenge in desensitizing had really severe reflux, and as we challenged them with aspirin, that got worse and worse. And they actually had to have a laparoscopic desensification before we could do their aspirin desensitization.
Is there one leukotriene modifier that you prefer?
But montelukast is the easiest because it's a once-a-day dosing. So generally speaking, you put them on montelukast. But you could use Affilade. So if you're leukotriene, you do it twice a day.
Kind of related to the half-life of that, do you give it the morning of desensitization rather than the night before?
Yeah, we generally have them on it beginning the week before, so you're hoping that they're kind of at a steady state level by the time they come in.
Gotcha.
Why is it that you stop their antihistamines?
Yeah,
It didn't seem like that makes
that's my
any difference.
It makes a difference in terms of being able. So our whole goal is to try and have a respiratory reaction that's just the upper respiratory tract. So you would like to have some symptoms develop so that you confirm that they really do have AERD. So avoiding that. But once they get their nasal ocular reaction, you can treat it with nasal decongestant sprays or oral antihistamines or intranasal antihistamines. Once you get that, then they can stay on their antihistamine. But we really like to have some symptoms develop during the challenge so we can confirm that they really do have AERD.
Kind of given the positive effect of this approach, if you have a patient with hyperplastic disease, let's say they never take NSAIDs, is it worth measuring LTE4 in the urine or actually challenging them? Yeah, or actually challenging them.
Yeah, so in terms of if you have someone who has, and you'll get that where they just don't ever take an anti-inflammatory drug, they're relatively young, it is worth challenging. And I'll give you, doing the urinary LTE4 is not very practical, but we have a protocol kind of mimicking what they do in Europe with the lysine aspirin, with using nasal Ketorolac, so you can use that as a diagnostic. But it's worth, if you have someone who has chronic sinusitis that's had more than one surgery, to put that on or off the table. So our original oral aspirin challenge took 2 days. We've always tried to make it relatively easy, but this process took 2 days. The details are there. We no longer do this procedure anymore. So now we use nasal Ketorolac, which you can also use as a diagnostic test. It has about the same sensitivity as the lysine aspirin, so it's not 100%. And the Ketorolac, you can get it as an injectable, comes in 60 milligrams for 2 mLs, and you mix it with 2.75 mLs of saline. We used to use the nasal port AQ bottles because it had a nice spray and it actuated a specific amount of spray, each volume, each spray. But it turns out now that you can get from compounding pharmacies that they sell these nasal spray bottles, and they too have the same volume of actuation. So you just measure to make sure that you have the right volume. But now it's very easy. We have 100 of them instead of having nasal spray bottles. And then we, the protocol is there on the left. So they get beginning at 8 a.m. through 9:30, increasing doses of Ketorolac intranasally. If you have someone who hasn't had the debulking procedure and they have nasal polyps or complete nasal obstruction, we can't do the Ketorolac challenge. What we found with the Ketorolac challenge is that it actually shifts, again, the reaction more to the upper airways, and makes the rest of the desensitization a little bit easier. You can still see bronchospasm even with the nasal Ketorolac, so you need to be ready to treat that. And you can also see laryngospasm, so have racemic epinephrine on hand to treat the laryngospasm. Once we get through the Ketorolac, we then do 2 doses of 60 milligrams of aspirin 90 minutes apart, and then they usually are gone by like 2 o'clock in the afternoon. Then they come back the following morning and get 2 doses of aspirin, and then they're done. That being if they don't react to any of the doses of the aspirin. If they do react to aspirin, you treat the reaction and then repeat that dose and then continue your desensitization. So what happens at the time of acute desensitization, their nasal I think I already did this. Sorry. Skip that. So the dosing for aspirin, 81 milligrams a day. If you took them all the way up to the 325 and then just maintained them on 81 milligrams a day, they're desensitized for cardiovascular disease prevention. You're not going to treat their AERD. That dose is way too low. At 325, they're cross-desensitized to all doses of NSAIDs. At 650, so our general recommendations would be to start 650 twice a day, and then about half of those patients will do better on 325. We're starting to look at some of these patients that we desensitized in the 80s. It's a bit challenging to find them, to find out what's happened over time. There's been some, we've heard back from some physicians where their patients actually stopped their aspirin and then started again and didn't have a problem. Others were able to get down to very low doses of aspirin. We just don't really know what the long-term outcome is on this condition. So safety is very safe. Then we had 3 patients that have had systemic symptoms, all responded to 1 dose of IM epinephrine. Again, just remember that you have an increased number of mast cells in these patients, and when you give them their aspirin and they have their aspirin reaction, the mast cells are activated and they do release histamine. You can measure high levels of tryptase. The average time to reaction is 102 minutes. There's a number of protocols out there where people are doing every 90 minutes on their aspirin desensitization. Sometimes you can get away with that. Sometimes it really comes and gets you in the end because you've given them a dose and they're just about to react on their previous dose, and now you have another dose on board. The typical provoking dose is between 45 and 100 milligrams, with typically about 80 being the provoking dose. The Ketorolac protocol decreases the challenge time by about 1 day, and it's cost effective. So what we know is that it decreases nasal congestion, the need for additional sinus surgery, the numbers of infections, improves their sense of smell, which gives them a profound improvement in their quality of life, improves asthma control, probably more indirectly by controlling the upper airways and decreasing the leukotrienes, reduces their need for burst of steroids in their oral corticosteroid use. So I'm going to switch gears just very quickly because you may encounter these patients more often than not in an acute care setting where you're not going to be talking about doing sinus surgery, etc. You're faced with someone who's just had go ahead.
On that same note, have you ever tried desensitizing patients that have just nasal polyposis and refractory sinus disease but don't have a history of aspirin sensitivity?
Yeah, so for one thing, you don't have to desensitize them. You can just treat them with high-dose aspirin, and that's been looked at. They don't seem to get better with the high-dose aspirin. They don't have this dysregulation of the leukotriene pathway.
I'm curious if anyone's, you desensitize these people, has anyone looked at adding nasal Ketorolac as far as time to polyp recurrence? Or?
Yeah, so Ketorolac is really hard because it's not very stable and you can't mix up a big volume of it. So Europe, they have their lysine aspirin, which is a soluble aspirin that's in a topical form, and they'll treat people topically with lysine aspirin. Their data is nowhere near as good as what you do with the oral aspirin. I'm not going to go into it in this talk because it could be the whole talk, but part of the reason that probably doesn't work as well is that it turns out that you need relatively high doses of aspirin to affect the changes. Part of it is the thought that aspirin is inhibiting STAT6, which then can lead to the downregulation of IL-4 expression. There's also some data that suggests that high doses of aspirin also are an inhibitor of NF-kappa B, which is an important transcription factor for pro-inflammatory cytokines. And then lastly, There's emerging data that's looking at the role of high-dose aspirin in terms of its ability to acetylate DNA, so that you may be getting some epigenetic changes that are occurring with the aspirin. And with the topical dosing, it just isn't high enough to achieve any of those outcomes. So for patients with coronary artery disease, there's a large percentage of patients, when you start looking at the charts, they claim that they have an aspirin allergy, and the alternatives are not nearly as ideal as using aspirin as your primary antiplatelet therapy. Things such as clopidogrel has risks for bad outcomes such as thrombotic thrombocytopenia or leukopenia. And if you had a patient that had some coronary event, is on one of those alternatives, and then need to have a CABG, you have to stop them at least a week before the procedure. So then you have a week where they're not on any antiplatelet therapy. Whereas if you're on aspirin, they can stay on aspirin and actually have a better outcome through their CABG. We looked at this, so if you talk to any allergist, they're like, oh yeah, aspirin anaphylaxis exists. And you're like, well, give me an example of one of your patients that had anaphylaxis to aspirin, not in the setting of AERD, because yes, the historical reactions in AERD can look in some ways like anaphylaxis because they get hives, but true aspirin anaphylaxis, we just haven't been able to identify it. There's, in the literature, there's like 2 case reports of people having positive skin tests to the lysine aspirin in patients that had aspirin-induced urticaria. But when you really look at the data, there's just no convincing data that aspirin, particularly we look at how many people actually take aspirin, you would think we'd be seeing a few more cases of anaphylaxis due to aspirin. So when you're faced with these patients that have an acute coronary event or an evolving cardiovascular disease, you really want to get the antiplatelet effect on as quickly as possible, and you really just need 81 milligrams a day of aspirin. When you look at some of the cardiovascular outcome trials, there was really no difference between low-dose aspirin and high-dose aspirin in terms of cardiovascular deaths, MI, and stroke at 30 days. And then if you looked at it, so if you're doing a stent or some sort of procedure, a vascular procedure, the combination of clopidogrel plus aspirin, the higher dose of aspirin was no more effective than 81 milligrams a day at restenosis in the first 48 hours, which are all the outcomes that the cardiologists care about and the patient cares about. So what you really want to do when you're faced with these patients is determine the likelihood of a real aspirin hypersensitivity. So we had one of our residents that did this retrospective chart review, I think of like 9,500 patients in the Scripps database across all our hospitals who had coronary artery disease, of which 142 or 2.5% had a quote history of aspirin allergy. And of those, when you actually went through and found out what their aspirin allergy were, only 21% were compatible with aspirin reactions. A large number of them were things such as easy bruisability, GI upset, tinnitus, etc. So the first thing when you're faced with it is to find out what the patient's reaction was to aspirin. I think more disturbing was the fact that of those 142 patients with aspirin allergy, only about a quarter of them were on aspirin prophylaxis. Of the other 108, only 25% were on alternative antiplatelet therapy, so they were missing a critical component of their standard of care for coronary artery disease. So the different types of hypersensitivity reactions to aspirin, we won't go through these in great detail. Type 1 we've just gone on previously with the aspirin exacerbated respiratory disease. They have this underlying chronic airways disease. Type 2 are individuals that have chronic urticaria, of which about 25% will have an acute exacerbation with a COX-1 inhibiting NSAID. The name for this is NSAID exacerbated cutaneous disease. Type 3 are individuals that do not have any underlying chronic skin disease, but develop urticaria angioedema with any of the COX-1 inhibiting NSAIDs. Type 4 are single NSAID-induced reactions, and the most common is ibuprofen. That was because it was the first NSAID to go over the counter. These are presumed to be an IgE-mediated reaction, and again, we don't see this for aspirin. And then there's type 5, which are these delayed type reactions, such as a fixed drug eruption, aseptic meningitis, etc. So for the patient that you're faced with that you now do think has a true history of reacting to aspirin or to an NSAID, the very first thing, they should really have their arterial lesion stabilized. So if they're going to need a stent, they should have a stent. Once the stent is in, you don't have to worry about like the coronary artery vasospasm or histamine release. They're a little bit more protected. We always like to have a one-on-one nursing with a physician on site, be ready to treat reactions. A lot of these patients come in, they get discharged within a day. They'll go from the hospital into our clinic to do their aspirin challenge, but oftentimes you may end up doing this in the hospital as well. So if you're dealing with one of the other aspirin sensitivities other than AERD, we really try not to pre-treat them with antihistamines, because what you want to know is, are they truly aspirin sensitive or not, so that in the future, if they skip 3 days of their aspirin, is it a problem for them to restart it or not? So we typically don't do any sort of pre-treatment. These are the patients that have chronic urticaria or a history of reacting maybe to ibuprofen. You do no pre-treatment, and we made it as easy as possible, because I don't know if you've ever tried to get varying doses of aspirin. It can be challenging, so we've done everything on a 81 milligram tablet of aspirin that can be cut with a pill cutter. You do 40.5 milligrams or half of 81 milligram tablet, and then repeat the dose in 90 minutes. If there's no reaction, then they continue with 81 milligrams a day. If for some reason the cardiologist really wants them at 325, I'll show you what you can do up to 325 at a later time point. So no pre-treatment, you give the 40.5 milligrams of aspirin, 90 minutes later give the second dose, and then maintain them on aspirin. So this is some of our data. We had 30 patients with aspirin allergy, 24 of whom had urticaria, 18 were associated with an NSAID other than aspirin, 6 were associated with aspirin. 6 had a history of anaphylaxis associated with an NSAID, again, none history of aspirin anaphylaxis. They all underwent aspirin challenge. This was before we had this protocol, so it's a little bit of variation, but the doses were doubled every 30 to 90 minutes until the full dose of aspirin was given. 28 were negative aspirin challenge, and 2 had mild urticaria that were treated with antihistamines, and they continued on their aspirin. When you look at challenge studies from around the world, there was a study that was just published in Australia where patients had some historical reactions to NSAIDs. The vast majority of the actual challenges end up being negative. In the second series, we had another 11 patients, and again, 1 had mild symptoms, but everybody was able to take aspirin. So for cutaneous reactors, the risk factors for reaction during aspirin challenge is a history of angioedema reacting to aspirin within the past year. Patients with underlying chronic urticaria, angioedema, if they do react to aspirin, can sometimes be challenging. Generally speaking, the 81 milligram dose is below the threshold provoking dose, so you can get them on 81 milligrams a day of aspirin. If you can't, and they're still reacting even at 81 milligrams of aspirin, you can treat them with oral antihistamines and add in montelukast or zafirlukast, and just keep repeating the dose until tolerant. Sometimes for these chronic patients, it can take a number of days in order to do it, and this all can be done as an outpatient because you're not worried about this turning into anaphylaxis, and interestingly, they don't get laryngeal edema. And then for AERD patients, so this is where you may encounter your AERD patient. If you have an asthmatic and you don't know whether or not they have AERD or not, and they don't have a history of recently taking aspirin, or they think that they are sensitive to aspirin, you can get a screening x-ray of the sinuses, just a Waters view of the sinuses. If they have no sinus disease, they don't have AERD. If you're uncertain and you just want to be very cautious, you can just treat them as a presumed AERD patient and treat them. Unlike the cutaneous reactors, we do treat these patients. We use montelukast and then corticosteroid long-acting beta agonists, even if they don't have any active asthma at the time. For the unstable patients, we'll also treat them with corticosteroids, either IV or oral, to stabilize their airways before doing their aspirin challenge. And again, it's the exact same protocol, so you don't have to remember two different protocols. We do 40.5 milligrams of aspirin, which again is typically below their provoking dose, and in 90 minutes repeat the dose again. Generally speaking, they will react at that second dose of aspirin, but you can treat it and then just keep them on 81 milligrams a day. The most important thing is that those patients who have only been taken to 81 milligrams a day of aspirin are not cross-desensitized to the rest of the COX-1 inhibiting NSAIDs. They're also not fully desensitized to aspirin, so they have to be very careful that they don't ever take a full-strength aspirin while they're on the 81 milligrams a day. But then you can discharge them and finish the desensitization in an outpatient setting, and that protocol is here. So who shouldn't be desensitized or challenged to aspirin would be anybody with a history of aspirin-associated Stevens-Johnson syndrome, which again is one of those that's very difficult to find any good case reports in the literature. There are good case reports of aspirin triggering hypersensitivity, pneumonitis, aseptic meningitis, or Tourette syndrome. And then chronic urticaria, again, you won't be able to desensitize chronic urticaria patients to aspirin if they are sensitive to the COX-1 inhibiting NSAIDs. But again, generally speaking, that 81 milligram dose is usually below their provoking threshold dose. So I'll leave it there and take any other questions or cases.
The people that are non-responsive to aspirin desensitization would, if it's eosinophilic driven, would mepolizumab be are there any case reports of that?
Yeah, so there haven't been any case reports of looking at that specifically. The name just went flying out of my head, but that dual IL-4, IL-13 inhibitor may be of more benefit. It seems that although you would think that the IL-5 would be a key player because it's such an eosinophilic-driven phenomenon, it seems really to be IL-4 is much more important than IL-5. So one of the IL-4 antagonists may be a better benefit.
And then on the 5-LO side, since Cytidin's pretty weak as a 5-lipoxygenase inhibitor, did you have any experience when Amir was developing that FLAP inhibitor that pretty much totally blocked glucotriene production? Has anyone looked at a more potent 5-LO inhibitor as a therapeutic option?
We were going to do a clinical trial with that, and it got withdrawn because I think of some liver issues, if I remember correctly. So we don't have any data on that. I mean, that was part of the problem. We used the 5-LO, and it wasn't as effective as shifting the reaction to the upper respiratory tract as the leukotriene receptor antagonist. Although, if you could do it in combination with like a montelukast or something, you might get a better outcome. Problem with that drug is that definitely had to be started previous to their arrival to the clinic, and so most of these patients are from out of town. So to get a consent form, it got too complicated trying to figure that one out. Yep.
Routinely doing the Ketorolac challenge?
Yes.
And is that basically just to hasten the procedure?
Yeah, to hasten the procedure, and to secondly to shift it again more to the upper. Our whole goal is to try and make it as easy as possible, so it tends to shift it more to the upper respiratory tract.
And when you're done, and basically you've done a challenge and you're at the desensitization point, you just continue
so
that?
you actually start the desensitization with the Ketorolac. So
it's a challenge and it's positive.
A diagnostic
and also therapeutic.
Helps. Yeah.
So, aspirin desensitization makes you tolerant of all the NSAIDs. Does it work the other way around? Somebody's had a reaction to ibuprofen, you rescued them. Can you assume they're tolerant of aspirin?
So if they had a reaction, so if you can get them in this window of opportunity when they've had their reaction, what you want to do is switch them from ibuprofen though and start them on aspirin. The problem with ibuprofen and a lot of the other NSAIDs is that they're competitive inhibitors of the COX-1 enzyme, whereas aspirin is an irreversible inhibitor of the COX-1 enzyme. So you're never quite sure as to how much blockage of COX-1 you have with the competitive inhibitors. It's been looked at if you treat patients with like naproxen, and you don't have as good of outcomes in terms of controlling their airways disease, which again I think gets back to this unique mechanism of aspirin maybe acting through inhibition of STAT6 or through modification of DNA or whatever it's doing that you don't see with the other NSAIDs. But yes, you can use that opportunity to start them on aspirin.
Are there any laboratory tests that are worth doing to screen people for this, or it's just historical and then?
Yeah, so it's historical. There's other conditions where you get elevated urinary leukotrienes, so that's it's not a good screening test to say you do have AERD. In Europe, they have like basical activation tests, but none of that's really been validated for making a diagnosis of AERD.
To maintain them on aspirin, do you often have to give them the misoprostol prophylactic?
No, actually, it's a small percentage of people that we have to do that. But when it does happen, it can be a rate limiting factor. So it's just a small percentage of people that we actually end up using misoprostol for. And the other, I was going to, just real quick, if you have a patient that misses 2 to 3 days of aspirin, can they simply take their full dose at home? And these are important things because invariably people go on trips and they forget to take their medication. So this is our general gestalt that if it's been less than 3 days, they just start back on their aspirin at full dose. If it's 3 to 5 days, they should start aspirin, and we do it at 90-minute intervals. Depending on the patient, depending on what their reaction was when you did their initial aspirin challenge, they could either be at home or in the office. If it's greater than 5 days, you have to re-challenge them and you can start at their provoking dose. And then lastly, we'll skip that. This is the surgery protocol. So some surgeons just are adamant that they can't be on full dose aspirin, so we have them drop down to once a day a week before, and then hold the aspirin 1 to 2 days before the procedure, and then actually be started in the afternoon or evening right after their surgery. Colonoscopy, even with polypectomy now, patients don't need to stop their aspirin. It's in the AGA guidelines. If they're on 650 twice a day, the gastroenterologist sometimes gets a little bit nervous, so you can do that same thing where you drop it down to 325 once a day.
All right, well, for those who can stay, well, as I said, we had no cases, now we have 2. If you want to try and squeeze through 2 cases in a half an hour, guys? Yeah, I don't, Lisa, did you have, I don't know which one is up.
I think, yeah,
We can let you sit down
Okay.
and be the visiting professor and those who do that.
Okay.
This is Dan Petroni, one of
Hi.
our first year
Nice
fellows.
to meet you.
So this was a case that actually an attending saw who was actually doing an aspirin desensitization today. I happened to be in clinic, and so I kind of overheard it and thought it was a very interesting case. So this is a patient who's a 54-year-old female with a history of hereditary hemorrhagic telangiectasia. It presents to the allergy clinic due to chronic sinusitis. She reported sneezing, rhinorrhea, nasal congestion, throat pain, watery eyes, and nasal drip. She feels that certain tree pollens in the spring and summer worsen her symptoms while she's here in Seattle. She's had 3 to 4 sinus infections per year, which have required antibiotics as well as steroids. She's also had a history of severe reaction to aspirin and several other NSAIDs characterized by angioedema and severe asthma exacerbations that required hospitalization. Currently, her asthma is partially controlled with a combination of LABA and IC gas. She has never been on any leukotriene inhibitors. She has a very strong family history and personal history of HHT with epistasis that occurs numerous times a day. It's actually worsening over the last 2 years or so. She's having 5 to 6 nosebleeds, as well as actually pretty profound bleeders that bleed through the back of her nose. Also, these lesions that bleed on her tongue. I mean, real profound bleeding. And she uses PRN aminocaproic acid to help control these bleeds. But she's never required a blood transfusion or iron transfusion for this. Her past medical history is significant for HHT, asthma. She had a hip replacement in July 2013. History of anxiety, depression, PTSD, some surgeries as well. Family history, she has multiple family members with HHT. Mother died. Okay. Her mother died of HHT at age 52 due to bleeding complications. Sisters require multiple blood transfusions. Has had laser surgery. Her son bleeds from his ears. No family history of allergies, asthma, or AERD. Medications: she takes Dulera, omeprazole, and the aminocaproic acid, albuterol, and trazodone is needed. Environmental history: has lived in Florida and Chicago and has lived in Seattle for the last few years. Lives in a motel, keeps a window open for climate control. And then she's a shipping clerk, former smoker, was a pack-eaten day smoker for 40 years, 2 years ago. Physical exam, no distress. Her skin shows, especially on her arms, is scattered telangiectasias. She also has, her conjunctives are okay, pupils are okay. Her ears are normal, canals are normal. Her nose, this is post debulking surgeries. Pain, no rhinorrhea, minimal mucosal edema, minimal crusts and clots in bilateral nasal cavities, no active oozing. Her oropharynx is normal, her neck is supple, no adenopathy, lungs are clear, no wheezing, heart is normal, rate of rhythm, abdomen soft on tenor. She has bilateral pitting edema with this macular erythematous rash on her lower extremities. Skin prick test was positive to dust mite, cockroach, and ragweed. Here's your spirometry. So, pretty severe obstruction as well as some restricted disease.
You did that skin testing here, or she came with that info? We don't usually test the cockroach and ragweed here.
Well, it's because of her. Sorry, I know.
Part of the regular panel here, even though we don't have cockroaches or ragweed here.
Yeah, because people are from all over.
Right. So that's probably her Florida. Yeah, that's where she was from. Here's her labs. CBC was within normal limits, and we did a basic immunoglobulin look at, and all that was normal. This was her CT scan in October 2014, when she presented to ENT clinic. They debulked, they removed an ethmoid, rather large ethmoid polyp, and they found it was an inflammatory polyp. A couple months later, this is just this past month, this is her, this is after debulking surgery, and she's like this. Like, once again, they're going to go back in and do it again. So they're going to actually go back in the maxillary frontal. They're going to do a full pan-sinusitis thing, as well as inside her sinuses, she has extensive telangiectasia as well, where they're lasering it as well.
And it's eosinophilic inflammation.
Yeah.
But she's had multiple surgeries. She's been able to do okay without bleeding?
Oh, they have to laser all these bleeders, so it's Dr. Davis has a lot of work when she comes in. Yeah, she's a rather complicated patient, and they decided to send her over to us just to look at for the allergy thing, and this is how she kind of presented. So I guess the ultimate question is, so what we did for her is we started on montelukast as well as like kind of all the nasal sprays. And we're considering starting her on dilutin. And the ENT's plan is to kind of go back in and kind of do all of this nasal surgery. But, you know, she sounds like she's definitely a classic AERD type patient, but can't put her on aspirin therapy because she's going to bleed. Is there anything else that we can do is our question for you.
Well, she's someone where I think omalizumab may be something that you would think about. There's some data out of Europe in these patients with chronic polyp disease that they get better on omalizumab. I think if you can address, I think adding the xylutine plus montelukast together to address kind of the overproduction of the cystinol lymphotrienes, and then consider something like omalizumab. I don't know how coverage is here. It might be challenging, but I think given her need for repeated surgeries,
You probably get it with her bad asthma. I think you get it covered.
Is the omalizumab, do you think it's starting with Nasal activation, or would be the primary mode that would be beneficial here?
Yeah.
And then what about what about mepolizumab though? Since that be approved fairly soon. What would you go? Would you go omalizumab first, or?
I think I would do omalizumab before mepolizumab because it just have been underwhelmed with its effect on kind of nasal polyps when they've looked at it, particularly like the European literature looking at the anti-IL-5. And yeah, does she have an elevated peripheral eosinophil count?
Not that I can remember because we didn't get labs on her. And her CBC was basic that the ENTs did. They were just looking for counts and platelet levels just to check for prior pre.
Because if that were up, because we do have that compassionate trial
for that.
Mepolizumab.
Yeah.
Okay.
As you know, I'll give a cyclosporin and methotrexate to almost anybody. Or put it in the drinking water. This is a chronic Th2-driven inflammatory disease. And those are, she's not on prednisone, right?
Yeah, not currently, no.
Not currently. So there's frankly nothing wrong with those old drugs. They really work extremely well. I have, although very atypical, I have about a half dozen people with chronic severe rhinosinusitis on cyclosporin. And they do very well if you monitor what you're doing.
But are those patients with AERD or just chronic sinusitis?
No, but I'm thinking of this in a different context. Since you can't do aspirin desensitization and aspirin therapy, that part of the issue is almost off the table in this case, and you have to think in a different way.
What's been your experience with the combo of the leukotriene antagonist plus xylutine?
It works well. You know, the problem is that one, it's super expensive still, even, and it's kind of a challenge to take because they're too. So people complain all the time about the size. I don't know. The pills are pretty big, so you have to do 2 twice a day with the xylutine. But it works really. It works well if they'll take it. If you can combine it together with the montelukast.
So at least it seems like that would be.
So that way, at least you're hitting the if you're presuming that a lot of this is due to AERD, then at least you're hitting the primary mechanism with that.
We got some suggestions there.
Yeah.
That's a challenging.
That's a challenging. Yeah, thanks.
Lisa, I don't know, did you work out the other case
I mean,
as well?
the other case, it's more kind of a historical overview of a patient and not quite as puzzling as stands. But
As I said, and you discovered this case apparently yesterday.
Well, Bill was talking to me what would be an interesting case. He's like, what about somebody who has aspirin bleeds? I was like, oh yeah, there was a person I saw a few years ago.
I just threw out a possible case and he had one.
can I pull out any of these flash drives here?
So not knowing
You can
that,
pull out the.
I have a case in my practice who you guys had desensitized down in San Diego. Yeah, this is an incredible situation. She was in allergy clinic yesterday, or
2 weeks ago. 3 weeks ago. It was Matt's patient.
It's Matt's patient?
I didn't see it. It was actually an ENT resident was with him.
But she took aspirin even though she has this hereditary. Had no one told her that that would be a bad idea. I mean, now I made it nice that you could make that diagnosis, but.
don't know. From what I can read from because I didn't actually meet her, what I can read from the chart, she sounds like an interesting woman. So, not exactly the most compliant of people.
This is actually my patient, and Lisa was nice enough to go through our office chart. She probably knows the patient better than I do because I haven't seen him in about a half a year.
Okay, so this is a guy who presented actually several years ago and diagnosed and actually and had desensitization at Scripps clinic. So I'm just going to kind of give an overview of its course over the last several years to kind of highlight some of the points from your talk. So this guy, he's now 47, but initially presented in his late 30s. Back in 2006 was the first time he'd seen it as an allergy, and at the time, his history of chronic rhinosinusitis, did have a history of sensitivity to aspirin, and had a recent diagnosis of asthma. He did have kind of that classic story that you were talking about, where he had a viral URI, and then for approximately a year and a half after that, he just complained of worsening congestion, rhinorrhea, developed anosmia, and also was having issues with chronic sinusitis, and had recently had a diagnosis of asthma kind of in that period of time. When he presented, he did have a couple of reactions that he mentioned. So actually, he'd been seen by an allergist in San Diego before moving here, and he was seen by us after that initial encounter. And that allergist had challenged him to 81 milligrams of aspirin, and he had symptoms with that, with increased nasal congestion, rhinorrhea, cough. He'd, subsequent to that, actually taken some ibuprofen on a separate occasion and had asthma exacerbation of the heart at that time. He was also followed by an ENT and did have a history of sinus surgeries and nasal polyps in the past. And basically, because of his severe nasal congestion, he was on steroids. He was getting frequent oral steroids and ended up, when we were seeing him on some every other day, 10 milligrams. He was also taking a variety of other meds. He had been started on Singulair. He was on inhaled corticosteroid and doing various nasal sprays. He also had a history of AERD. She was on tonics and as I mentioned, steroids. Spirometry, when he initially saw us, he had skin testing as well and didn't have anything significant in terms of skin testing. His IgE level had been looked at as 5, so it didn't seem to be particularly allergic otherwise. And as I mentioned, due to the pretty severe nasal congestion and steroids, he was initially seen in our clinic. He was referred to the Scripps clinic for desensitization. That was back in June 2006, and at the time it looked like the protocol was the oral aspirin challenge. And so he, on the first day, seemed to do okay, and then on the second day, when he was given the 100 milligram dose, within an hour, he developed nasal congestion, rhinorrhea, ocular rejection, a slight drop in his FEV1, but nothing too significant, and he was on the asthma medications and steroids at that time. His symptoms resolved with some Acetylene and Patanol, and then he was able to tolerate the 325 milligram dose by the day. So he was on 625 BID. He left, and he actually reported pretty significant improvement in his congestion following that. However, he did kind of have a rebound in his nasal congestion. His anosmia persisted. It didn't sound as if he'd had any sinus surgery just prior to the desensitization, and so he ended up needing to go for sinus surgery. His ENT actually, at the time of surgery, noted that he had fungal sinusitis present, so he was treated for that on a combination of antibiotics and antifungals. And he was feeling much better following the sinus surgery. However, at that time, the ENT didn't feel comfortable doing the procedure on aspirin, so he asked him to go off for 2 weeks prior to the surgery and then remain off of it afterwards. So he ended up having to go back to the Scripps clinic for a repeat sensitization. So he went back in February of 2007 and had that done. And following that time, he's still been followed by ENT. They have not noted recurrence of his polyposis, but he's continued to have issues with his sinus disease and his asthma from time to time. This seemed to be ameliorated in part by kind of escalating his asthma, where he's now had the HFA 2 BID instead of just QVAR, and that seemed to help. He's been started on intranasal budesonide, which he does kind of to a varying degree on how he's doing. And that actually seemed to help a lot. He's been much more stable on that regimen. Over time, was able to reduce his aspirin to 325 BID and has remained stable. In general, seems to be doing much better these days with regards to his asthma and sinus disease, but does have flares of both from time to time. He gets ill. sounds like he's a pretty avid hiker. He's quite active and he's exercising his asthma sometimes. But with regards to the congestion, nasal polyps, etc., that all seems to be much better desensitization. And his steroid use at this point is really just related to occasional sinus infections and asthma. So that was kind of just an overview of the case that Dr. Allman saw. I don't know if you have any comments about things that came up, or kind of highlight some of the things you were talking about with regards to, tailoring approach when you come up to surgery, trying to avoid
I think that's a little bit easier now because there's all this accumulated data, so we can really push the surgeons to kind of, if you can drop the dose down to aspirin and then stop it 2 days before, there's really no need to do a bleeding time or anything like that. It doesn't really get you any useful information. But that makes such a difference. I mean, for that poor guy to have to go down twice to get desensitized, now he doesn't have to go anywhere. But that's fairly typical where it gets stopped for some reason. It's always interesting that they still kind of flare from URIs. So again, it gets back to the point that their asthma does not resolve with aspirin desensitization. So that's kind of interesting.
I forgot, have we never considered omalizumab for
So
him?
it was, again, his IgA was 5, and he had a couple different insurance companies that he petitioned to consider, and it sounded like they never got approved. And again, no other signs of aging in regards to skin tests or other history. So.
Over the years, we've gotten people well below 30 and well above 700 approved, but obviously not him.
Yeah.
Probably somebody you saw
I'm sure.
in your career before he moved here. Most all of this work was done in San Diego, and then he moved up here.
Is since excess-induced asthma seems to be system of leukotriene driven, do people with aspirin exacerbated disease
Have more
exercise
have
induced
EIB.
asthma?
Yeah, that's a good point. I just thinking through that as you started to ask that question. I don't think we've ever looked at that. I'm sure it's probably one of our survey questions if they had exercise-provoked symptoms. So I don't know the answer to that.
Yeah, you'd think it'd be even more prevalent there.
We'll see you this evening.
Yes, thank you.
Chris is going to take care of you during the day.
Yes.
You go on.
Yes.
All right, thank you guys for presenting.
So Dan, maybe if you can talk to Matt about the omalizumab,
Yeah,
like that
I think we can get it for her. She's allergic.
The positive.
She's allergic. She's got bad asthma. I
Plus,
can
it's
get it.
direct observational therapy, right?
Yeah, that's true.
But what if it's worse? She could have that.
Yeah, that's terrible. Right?
I don't think I've ever seen a patient like that.
Yeah.
Amy, you're going to take care of the room?
Yeah.
Thank you very much.
So you have
Thank you, Amy.
this evening?
What we got is
So have you done, how's your aspects?
It's done well. Yeah, they've Matt